Good morning, everyone, and welcome to today's Carer Knowledge Exchange interactive webinar, Innovation in Carer Health. My name is Lucas Hofstetter. I'm the Manager of Research and Development here at Carers New South Wales, and it's a pleasure to welcome you today. This webinar has been shaped together with our facilitator and our guest speakers, and it's great to see so many of you to join us today. Before we begin, I would like to acknowledge the Gadigal people of the Eora Nation, the traditional owners of the lands where this office is located. I would like to pay my respect to the elders past and present and extend that respect to all Aboriginal and Torres Strait Islander people here today. I want to provide a brief overview of the Carer Knowledge Exchange for those of you unfamiliar with the project hosting today's webinar. The Carer Knowledge Exchange is a knowledge translation project led by Carers New South Wales with funding from the New South Wales Government. We aim to connect research to practice, to improve outcomes for carers. And one of the main ways we do this is through interactive events. I should also note that this project understands carer as someone who provides care and support to a family member or friend who lives with a disability, mental illness, alcohol or drug dependency, chronic condition, terminal illness, or who is frail due to age. Today's session will be facilitated by Giselle Gallego, a Senior Research Fellow at Translation Research at the University of Notre Dame, Australia, and a valued member of the Carer Knowledge Exchange Steering Committee. Thank you again for being part of today's webinar. I will now hand over to Giselle, who will guide us through the discussion and introduce our guest speakers. Welcome, Giselle.
This is a nerve-wracking time when you hope everything works. Thank you very much, Lucas. So my pronouns, I'm Giselle Gallego, I'm pronounced as she, her. My visual description today, I am wearing a tight bun to the back and a black dress. And it's an absolute pleasure to guide this conversation today. So we'll start with the housekeeping. Please note that today's session will be recorded as in the chat and shared for on-demand viewing. We ask you that for the first hour of the webinar, everyone that is not part of the panel, please mute your microphones and turn off your cameras so we can focus on the presentations and panel discussion. We recognize that we have many carers and others with lived experience join these seminars. If you hear something that causes you distress and you need to talk to someone, we have a well-being officer available online who you are welcome to contact. Further information about how to do so will be posted in the chat now. Today's webinar brings together an amazing lineup and participants from diverse backgrounds and areas of expertise. So that's an absolute delight. And our aim is to create a positive learning environment for all participants that is based on kindness and respect, where all perspectives are valued. You're welcome to add questions and comments in the chat throughout this session. However, to help us connect with you, there's going to be a quick poll and it's going to be lunch and it's going to appear on your screen. I would really appreciate if you could take a moment to respond before we begin. So the poll is going to be lunch. Just take your time, think about it. I'm just going to give you some background to the session and the outline. So across the Carer Knowledge Exchange activities, including our interactive webinars, which is the one you are attending, and there's also the annual research incubator, and throughout ongoing conversations with carers, researchers, policymakers, and practitioners, one message continues to come through clearly. Caring can have a significant impact on a person's health. Yet, despite these, carers' own health needs are too often overlooked or left unrecognized. So I think most of us in the chat recognize this online. So bringing together lived experience, research, and policy perspectives, this webinar will highlight practical ways we can better recognize carers and support their health and well-being. So I'm going to introduce now, just give you a couple of seconds more to fill in that poll, and then I'm going to introduce our wonderful panelists today. And as I mentioned before, they are quite diverse and they bring a wealth of experience. So the first speaker is Chiara Roche. Chiara is a carer, an advocate, a lived experience researcher, a Carers New South Wales care representative, and a New South Wales Care Advisory Council member. Welcome, Chiara. We also have Ainsleen Lalor. Ainsleen leads the Aging stream at Monash University's Rehabilitation, Aging and Independent Living Research Center. With a background of occupational therapy, she brings both research and practical experience to her work and is passionate about supporting healthy aging. Her current work focuses on developing and testing co-designed care, health, and well-being service for older carers, as well as delivering an interactive virtual program in aged care settings across Victoria, New South Wales. Welcome, Ainsley. And then we have Luke Rober, who Luke is an experienced coordinator of Aboriginal specific disability and aged care services. He's a project manager, Aboriginal scholarships. He's a project manager of Aboriginal scholarships and higher education, GP recruitment for Aboriginal medical services, and care of 2 teenage boys in out-of-home care. Welcome, Luke. Our final speaker, Melissa Docker, is the Acting Executive Manager, Policy Development and Research at CARES New South Wales. Melissa will share insights of the General Practice Awareness Project and the importance of identifying and supporting carers in health and care settings. We will begin by hearing Kiara, who will share her lived experience as a carer, including how her caring role has influenced both her mental and physical health. Over to you, Kiara.
Morning, everyone. My name is Kiara Roche, and I'm 26 years old. I'm a mother, an advocate, a student, a care representative, and a lived experience researcher. But long before any of those titles, I was a young carer. My caring journey began in childhood when I was 8. I cared for my mum, who lived with mental ill health and addiction challenges, and for my brother, who has autism. Growing up as one of 5 siblings, our family life was, as you can imagine, unpredictable and often overwhelming. While other children my age were going to sleepovers or worrying about weekend sport, I was learning how to read my mum's moods, manage her medications, and take my brother to and from his multiple therapy and medical appointments. Fast forward to today, I'm now a carer for my 5-year-old son, Ryder. Ryder has level 3 autism, global developmental delay, and pathological demand avoidance. Caring for him is a full-time role requiring constant advocacy, therapy appointments, and hands-on support with his daily living needs. Caring has shaped every single part of my life: my education, my career, my identity, and my mental health. It has given me resilience and purpose, but it has also taken a toll. I live with anxiety, depression, complex PTSD, and at 18, I developed stress-induced seizures. Caring is both beautiful and incredibly rewarding, but it is also complex, messy, and permanently life-changing. By the age of 15, I had already been admitted to psychiatric hospital 3 times. I was seeing a psychologist, my school counsellor, and even a court-appointed psychologist. In other words, I had a lot of professionals around me, and yet not one of them identified me as a young carer. Not one of them gave me the language for what I was experiencing. I didn't even hear the term young carer until I was 22, when I was desperately searching for help for my son. If you take one message away from my story today, please, I beg you for it to be this: young carers do not have a single look. We don't fit into neat boxes or tick lists. We exist in every single classroom, every hospital and waiting room. Each of us has a unique story, and each of us carries responsibilities that are often invisible. We are the hidden infrastructure of care, holding up the weight of a system that depends on our unpaid labour, emotional resilience, and endless adaptability. But being unseen comes at a cost. One of the greatest barriers young carers face is the fear and sometimes the reality of being reported to Child Protection Services. When I was 16, I was working 3 jobs and still managing top grades at school. Then my brother became critically unwell and spent 3 months in intensive care. I stepped in without hesitation, staying overnight with him in hospital, caring for my 3 other siblings, and supporting my mum at home. And that meant I missed some school. Instead of support, both the hospital and school reported my family to child services. On paper, I was labelled parentified and neglected. I was a young carer doing absolutely everything I could to keep my family together. Even after explaining my responsibilities, no one offered help, resources, or understanding. For the next year, my family lived in fear, afraid I would be taken away simply for caring. That experience taught me something that I will absolutely never forget, and that is, for young carers, being seen can sometimes mean being at risk. On top of this, I was told I had 2 weeks to catch up with 3 months of missed assignments or face expulsion. So at 16, while barely holding my family together, I was given an almost impossible ultimatum instead of the support I desperately needed. Young carers who look like they are holding it all together still need help. They need formal support networks, practical assistance, multidisciplinary meetings, and just 5 extra minutes with trusted services and formal support networks. In my experience, young carers hold it together until we don't. I was a grade A student placed in gifted and talented classes, and I still to this day maintain a strong GPA at uni. Yet I dropped out 4 weeks before my final ATAR exams. I do not have a Year 12 certificate. Capacity building for young carers, even high-achieving coping ones, can be make or break. A young carer can be well-spoken, achieving great grades and have no behavioural challenges and still not have their first dentist appointment until they are 20, where a dentist has to teach them how to brush and floss. That child was me. Yes, it could be classified as neglect or parentification, or it could be understood as a young carer who needed someone to step in and take some weight off their shoulders so they could remain strengthened within their own home. By 6, I could navigate public transport alone. By 8, I could confidently speak to Centrelink, the Department of Housing, Medicare and GPs. I knew how to advocate, I knew how to survive. I did not have a mother who had the capacity to teach me basic life skills, but I absolutely knew how to get my brother to and from therapy appointments and how to call the Salvation Army for a food voucher for the 12th week in a row. But at 21, I took a nurse in the delivery room to explain basic self-care. It took me until my late 20s to learn how to care for my hair, my body, and my mental health. Later, I was told my needs were too complex for early intervention mental health services, yet not severe enough for hospital admission. I was bounced between professionals every few months, retelling the exact same story over and over again without ever receiving consistent care. Eventually, I disengaged from the system completely. Every door I knocked on led to another referral, another waitlist, another person who didn't understand that I wasn't just a patient, I was a carer. And that is the exact point where my addiction began. As a teenager forced into adult responsibilities, trying to cope with the weight of caring alone and keeping my family together. What started as a way to escape fear and chaos, became my only means of coping. My 6-year-old struggle with addiction wasn't about rebellion, it was relief, and recovery wasn't just about sobriety, it was about being understood. Recognition matters because a young person who appears non-compliant, self-harming, or using substances may not be defiant. They just might be carrying the weight of an entire household. So I ask you to think about this. If a young person has to reach a breaking point before they can access help, what message are we sending them with? What choices are we leaving them with? In my own experience and in conversations with countless carers, when young carers are left without support, they absolutely will find their own ways to cope. Unfortunately, those coping mechanisms are often born out of pain, not choice. Too often, they take the form of self-harm, substance use, or other destructive behaviours. When young carers stay invisible, the consequences are devastating. The exhaustion turns into burnout, the burnout becomes crisis, and in some cases, that crisis becomes life-threatening. Even when young carers do try to access care, the system is often inaccessible. I want you to imagine this. You're in crisis, you need to go to therapy, or you need to be admitted for your own safety, but you can't because you're the one who has to administer your mum's meds, you're the one who has to get your sibling to their therapy, you're the one keeping the household running. You have to choose between money for groceries or the psych appointment you waited 8 months for. For young carers without informal support networks, it can feel like there is no way out. For disability support providers, health professionals, educators, and community services, it's absolutely important to understand this reality. Many young carers support a sibling, parent, grandparent, or friend with disability, chronic illness, mental ill health, or complex medical needs, yet they may absolutely never identify themselves as carers. Often, they see it as just what they do. In culturally and linguistically diverse communities, including my own experience as a Ukrainian woman, caring responsibilities are often viewed as a natural family duty rather than something that warrants external support. These roles are not always obvious. They can include checking medication, managing emotional regulation, supervising behaviours, helping with personal care, translating for parents, attending appointments, or quietly making sure school bags are packed and routines are maintained. This responsibility lives in the background of a young carer's mind every single day. Professionals across all sectors, including disability, healthcare, education, and the community, often see the most intricate parts of people's lives. They see the family, their routines, the stress, and the dynamics. My son's support workers have witnessed me at my lowest, in the pits of burnout, and have also stood beside us in some of the most beautiful moments of his life. As the main point of contact, you notice when something feels off, when someone is stretched too thin, or when a young person is carrying more than they should. While your formal role may be to support the identified patient, student, or participant, recognizing and flagging a potential young carer gives you the power to intervene in ways that can change and most likely save a life. This is where professionals can make a difference. You can ask, who else do you care for at home? What responsibilities do you have outside of school? You can provide practical support, like assisting with NDIS applications, connecting to peer workers or carer support services, coordinating care, arranging in-home supports, offering flexible appointments or meeting times, or even just helping with a simple phone call. These small actions will and can be life-changing. Beyond individual action, the system itself has a responsibility to recognise and support young carers. This means adopting strengths-based approaches that trust and value young carers' intuition, perspective, knowledge, and skills, no matter their age. Strengthening support at key transition periods, improving cross-sector communication, and creating carer-safe, culturally inclusive environments where young carers feel safe to identify. People often ask me, what can we do to help? How can we help? This is how. This is how we ensure that no young carer slips through the cracks. Inclusion, equity, safety, resourcefulness, awareness, and systemic change. Support can work, and I know this because I've experienced it. Carer Gateway Counselling became my lifeline, the first time I was ever seen as both a carer and someone struggling. I was fortunate to work with professionals who recognised the responsibility I carried. That understanding made recovery possible, and directly because of their compassion and belief in me, I now have almost 8 years of sobriety. My son has never known his mum in active addiction, and today our home is built on stability, love, peace, not chaos, not pills, and not alcohol. I've also been lucky to have therapists who come into our home, trust my expertise as his mum, and treat our family as partners in his care. That trust and respect has been so incredibly validating and rewarding. It reminds me that good support exists and it thrives when professionals walk alongside families, not above them. This is what young carers need more of. Professionals who see us, believe us, respect us, and walk with us. At the heart of every young carer's story is the very simple truth that we don't need saving, we need seeing. We need support, we need action, we need inclusion, and we need change now. Caring is not just a part of my life, it has defined it. It has tested me, it has shaped me, and it has also given me purpose. I share my story not for sympathy, but for change. I want us to imagine a world where young carers are recognised early, where teachers, doctors, and social workers know what signs to look for, where young carers are not punished for their responsibilities, but supported in them, where accessing help does not mean sacrificing your family's well-being, where no young carer feels they have to reach crisis point or turn to harmful coping mechanisms before someone steps in. That world is possible, but will only exist if we together commit to making it so. Thank you.
Sure, I am speechless in a good way. Like, this is so powerful. Thank you very much. And there's no such thing as the lived experience. No one can walk in your shoes. And I am absolutely humbled by your experiences. So thank you for sharing them with us today.
Thank you.
And we will have time. And there's lovely comments in the chat. Please have a read. And the next speaker and our next presenter is Dr. Ansley. I'm going to put the slides up, and Ansley is going to talk to us now.
Thanks so much, Giselle, and thanks so much, Kiara. What an amazing presentation. Like Giselle was saying, thank you so much for sharing your story and definitely for advocating in the space for young carers. As mentioned, my name's Aslan Layla, and I'm a Senior Research Fellow at the Rehabilitation, Ageing and Independent Living, or RAIL Research Centre, and also in the Department of Occupational Therapy at Monash University here in Victoria. I'd also like to acknowledge the traditional owners of the lands where I'm joining from today, the Wurundjeri, Woi, Wurrung and Bunurong peoples of the Kulin Nations, and pay respects to their elders past and present. And my presentation today is going to sort of shift to the other end of the lifespan and look at older carers and share some key insights and reflections about a co-designed carer health and wellbeing service that myself and my team have been running for the last couple of years. And this is my team here, so I'd just like to thank them for their input. And as you can see, it's a broad multidisciplinary team. So before diving in to the particulars of the service itself, I'd just like to provide a brief snapshot of what the service is and how it came to be. So our team was obviously curious to learn more about who cares for the carer and what carers need in helping them to improve their own health and wellbeing. And so this led us to complete 3 phases of work in the last 5-10 years or so. So we conducted a very comprehensive national survey to explore further about what carers' needs are and what they're saying about what the supports are that they're getting or not getting. We also conducted interviews with carers and health professionals to get the perspectives of both groups regarding the needs of older carers. And then we also conducted co-design workshops with key stakeholders, including carers and older adults. And this was to co-design the model of care that underpins our service. And this drew on the findings of the first couple of phases there. So the Carer Health and Wellbeing Service aims to support informal carers, so carers who are 50 years and older, who are supporting someone who's 65 and over. And while we know all carers need support, as clearly identified in that first presentation, older carers usually also have additional health challenges as they're aging alongside the person that they're caring for in that caring role. So their health can be exacerbated as they age. So we ran a pilot of the service over the last 2 years, which included a team of allied health professionals working together to deliver a range of supports to help address the self-identified health and wellbeing needs of older carers. And that's been a key component of the service, is that it's carer-driven, so it's focusing on their identified needs, not what we assume or think that they need. Carers are involved with the service for about 6 months to address and problem solve those needs. And our team included a psychologist, social worker, occupational therapist, and physiotherapist. And this was all driven through that co-design of the needs that carers wanted a service to be able to deliver. And the staff represent obviously their respective disciplines, but work together to optimise the carers' capabilities and empower them through problem-solving approaches to address their needs. So through engaging older carers, this has been obviously central to the success of our service, and the key focus has been about connecting with and hearing from older carers in a range of ways across the project timeline. So firstly, carers were involved throughout those 3 phases that I mentioned before about the conception of the service itself. We also undertook a range of evaluation mechanisms over the last couple of years so that there was continued refinement of the services approaches based on the lived experience perspective. So this included interviews, surveys, and general feedback from carers. We also had an advisory committee and consultancy groups, which included carers, and these groups have provided invaluable guidance, ensuring that the service attends to the broader project activities that are needed and it remains relevant and effective. Another key strategy was the involvement of older carers in public launch events. And these events not only featured presentations by carers themselves, but also served as a platform for sharing real life experiences and insights. And this approach has helped to ground the service in genuine needs and expectations of what the carers are needing and wanting from their own perspectives. And so as we're aiming to work towards future funding for this service, unfortunately, it ceased at the end of last year. So we're currently actively looking for additional funding to re-establish and extend that service so that the engagement of older adults will obviously remain a cornerstone of that for us to do it. I'd like to now share, with permission, the journey of one of our carers who attended and was part of the Carer Health and Wellbeing Service. So Nancy was looking after her husband with dementia, and you'll see from quotes as I bring them up on the slide some of her experience. So Nancy's story highlights the synergy of combining disciplines like OT, psychology, and physio, and she found the integration of services not just beneficial but transformative for her. And Nancy described the collaboration as fabulous and emphasised how everything worked together and therefore worked for her at the point of contact that she needed with the health system, rather than having to go to multiple or try and navigate the system. It was in one location. Nancy also highlighted that this holistic approach provided her with hope and practical strategies to break free from a rut, and that it also allowed her to reflect and work on her issues, through which she found an understanding of what was her husband's experience was, but it also enabled her to be able to regain affection for her husband as her role had transitioned to being more a carer, and she sort of lost that connection as a spouse. She also expressed immense gratitude for the support the service provided and described it as life-changing. And she also said, as you can see there, I walked out of every session like I wanted to skip home, which illustrated her feeling of empowerment and being re-energized. And this highlighted the importance of meeting the needs of older carers and helping them to give themselves permission to address their own health needs and not to feel guilty, in order to continue to help others, like her husband. So, following that example of Nancy's personal experience, I'd like to share with you all now some of our broader learnings and insights from the wider group of carers who engaged with our service. And firstly, having the right foundation of the service was key. So, many participants who took part in the evaluation, this included staff, carers, and also people who referred carers to our service, expressed that the service is both acceptable and valuable in meeting the needs of carers. And this was reflected through the core structure and missions underpinning the aims of the service itself. The service's responsiveness was also a standout feature. The absence of a wait list and the ability to promptly arrange the first appointment were greatly appreciated by carers who were in need, and this quick turnaround is vital in ensuring that carers feel supported and can access help when they need it most. And the service was also provided free, so that was also another aspect of that accessibility. Another critical factor was having the right staff, and the carers found the staff to be knowledgeable, supportive, and provided practical strategies to tackle their self-identified issues, and the benefit of having that breadth of disciplines that they could access. It was also instrumental in not only addressing their immediate needs, but also empowering them to manage ongoing issues. And a couple of the carers mentioned things as it wasn't just the physical, but it was also the mental things, and providing a crutch for support. Another carer put it helped them through. So lastly, the service enabled carers to feel heard and valued, and the ability to be able to speak freely with and feel genuinely listened to was an important aspect of the support provided, fostering a sense of respect and empowerment for the carers involved. And these learnings to date demonstrate that just from that pilot over the last couple of years, the service is acceptable and feasible to deliver. However, we actually also acknowledge that there's a number of challenges, despite the positive learnings, for us to be able to continue the service ongoing. And it's crucial for us to obviously understand how we can continue to improve and expand the service for future delivery. So firstly, one of the main areas for improvement was promotion and access of the service. So many carers noted that they didn't identify as a carer, or they weren't aware that there are services that exist to support them, or that if they don't identify as a carer, then they don't know that there are services for carers, if that makes sense. So once they knew about it and accessed it, they expressed the need for there to be better promotion of the service and for greater recognition of people who we identify as being a carer, that we can help them to realise that they've taken on the role as being a carer. Further, it was highlighted that some people who attended the service had limited awareness and understanding of the 4 disciplines that we had working there, so the OT, physio, psychologist, and social worker. So in the latter part of the service pilot, our staff were running various education sessions with carers, and predominantly these focused on topics that like sleep or exercise, relaxation, but it was also suggested that some of these sessions could educate carers further to what the offerings are that the different health professionals might be able to offer, so they had a better understanding of that. Another significant challenge was logistical considerations. And while this seems a small thing, cumulatively, it becomes a bigger issue. So factors regarding the limited funding, the physical location of the service for accessibility, parking, public transport to access it, as well as opening times. So for our pilot, we only had funding for clinicians 2 days per week and at one location. Additionally, while telehealth was an option as a flexible mode of service delivery, nearly all older carers preferred in-person appointments, and all these factors are vital for accommodating the time constraints faced by older carers to be taking that into account. Further, staff themselves highlighted that because they were only working 1 or 2 days per week, this meant that they had higher administrative loads, less time to be able to address the needs of the carers themselves. So if they had been able to work across the week, then they would have had more opportunity to see more carers, and that sort of baseline administration load would have been spread. Lastly, there is a call for expanding the team to include additional personnel. So this was through both in our co-design at the very start, but also throughout the service itself. But based on funding, we didn't have the opportunity to do so. But to include a nurse, so general and mental health nurses, to address a broader range of medical needs in order to enhance the holistic care provided by carers. And this is something we're hoping to work towards with the future funding that we're trying to get. So from the learnings and challenges, it's important to obviously distill what we've learned so far into actionable steps. And first, obviously, like we were mentioning, the logistics truly matter. This is not just about where the services are located, but how they're delivered, how they're scheduled, how they're made available. So older carers face significant time constraints. They're often governed by the needs of their loved one and the various appointments that they've taken that person to, or services coming into the home. So ideally, if the service could operate 5 days per week as well as across more locations, this would optimize how carers might be able to take advantage of the service. With us being only able to offer it a couple of days a week, that meant some carers, they were just never available on a Wednesday or Friday, so they just weren't able to access the service. Secondly, carers have distinct needs, and recognising these is crucial. So with the support of various health professionals to work through them, this is really important for us to better understand. Also, the focus should not only be on the physical needs, but also on mental health and well-being. And this has been really a key area of our evaluation data so far, which suggests that a service like ours can have a significant impact for carers. And certainly there was a greater demand for the social work and psychologist within the service, and they had a greater FTE, which is like how many hours that they were working per week, was a greater proportion, because we knew prior to going into the service, based on that underpinning co-design, that carers identified mental health was probably the biggest aspect that they wanted to be addressed. Next, many services that are currently available are limited in addressing the carer. So our health system is predominantly set up to address the needs of the patient, and this is predominantly the person that the carer is caring for. So in Nancy's situation, she was attending appointments for her husband because of his cognitive needs. And so additional funding or support is essential to have a service like the Carer Health and Wellbeing Service, so that we can advocate and make meaningful action to address carers in addressing their health and wellbeing needs. And lastly, it's vital that we have firstly able to identify loved ones, spouses, adult children, neighbours who are providing support as carers. So as I mentioned before, oftentimes they themselves don't identify as a carer. So we need to help them to be able to recognise that they are, and so that this can open opportunities for them to access services. And then also within health appointments, that the health professionals recognise that the person attending with the care recipient is a part of that role in that health professional aspect. And lastly, I'd just like to thank you all for listening today. And if you need to or would like to contact me, my email's on the screen there, and I'll happy to chat in the Q&A as well. Thank you.
Thank you very much. It's so great to also it highlights the heterogeneity of caring, right? There's different younger carers, older carers, sandwich carers. And so we're transitioning now to Luke.
Thank you, everyone. My name's Luke Roma. I'm project manager at the Aboriginal Health and Medical Research Council. We've currently got a partner project with Carers New South Wales. Also got some interesting lived experience I'd like to talk about today, but if we can just go to the next slide, please, Lucas. I just want to say Yama, Gabaninda, everyone. Luke Roma, Gomroy Murray Gull, Baradine, Billigagayalu. So that's Gamilarey language. Thank you, everyone. I'm Luke Roma, a Gomroy man from the areas of Baradine and the Pilliga that I belong to. So if anyone doesn't know where Baradine and the Pilliga Scrub is, it's sort of a couple of hours over towards the coast from Dubbo. It's the largest inland forest in Australia. One of the reasons I start with my original language is because, and as I'll go to the next slide, we've got in Aboriginal languages, we have no known word out of 500 languages for disability. So one of the reasons that this I think matters to us is because we are used to being communities that adapt and overcome. This picture here is me and my 2 teenage nephews that live with me, who also have lived experience of being young carers who looked after their mother, who had some quite serious addiction issues. So, I resonate with a lot of the things that Chiara, mentioned earlier in her presentation. This is Luke and Chase. They're 13 and 15. From basically as long as they can remember, they've had to look after mum, who had some addiction issues, and they now live with me. Mum's addiction issues actually formed by looking after her father, the boy's grandfather, as he passed away of lung cancer over a few years. And so she self-medicated with alcohol and drugs, and it's now turned into a quite serious problem that we're struggling to get assistance with. One of the things about the boys' experience with this, though, was that it meant that they missed a lot of school. It also meant that DCJ had intervened at certain points, and a lot of the time it looked like cases of child neglect and things like that, when really it was sort of the kids looking after mum, not mum looking after the kids. And so these are the types of things that as Aboriginal carers we often face. Like we've got a history of government intervention in our families and things like that, and so I think it's really important that that our stories are highlighted. And also for young carers especially, I think we talk about identifying as a carer. These guys didn't know they were carers. That was just mum. Like there was no label for it in the family unit. In our family units, we don't really see things like this as anything other than our social responsibility, and our responsibility to each other. And so we'll grab just the next slide, please, Lucas. Yeah, and as I mentioned, there's no known word for disability in Aboriginal languages. And when I say disability, I suppose in this context, I mean, like aged care and frailty and things like that too. Like we don't really have those types of words in Aboriginal languages. We're very much a community that looks after each other and adapts to change. So the things I want to talk about today is community resilience and ability. And these are things that, while I'm speaking from an Aboriginal perspective, I think that these are, strengths that all carers possess regardless of cultural background. The next slide, please. So community. So Aboriginal carers are often underrepresented in statistics because our traditional community structures are based around adapting to differences and caring for each other. Working with our individual strengths and skills to provide benefit to our mob and our family unit. And I think something that's in Western society that we've probably lost a little bit of the skills to do. We see that many other cultures are a little bit better at looking after their old people or their frail people and things like that. And the family unit is a stronger, larger unit, like than often in Western society, and the sort of individualism that we live with, a lot of us, So for this same reason, though, it means that Aboriginal carers can be quite reluctant to seek support or apply the label of carer to themselves. Like I know for, my kids in that situation, they were very, very scared to tell anyone about what was going on at home because it might mean that the police will come or that somebody's going to come and take them away from mum. So it also means to them, they're worried about that who's going to look after mum if they get taken away, but also that mum's going to get in trouble. And none of these things can be approached in that way, like from an angle of helping or supporting. And it's, our traditional roles in community, like have almost always included looking after our elders and raising, children of our relatives and caring for each other. Next slide, please. And so resilience is one of the other things I want to highlight. So 59% of Aboriginal carers care for more than one person at home. 81% of those Aboriginal carers identify as female. And just on that, I think something like 60% of those Aboriginal female carers also have an average age of about 46 years old. So these ladies are also already our mums, our aunties, our nanas, and things like that, right? And so rather than sort of representing them as a statistic, I'd like to just really highlight and acknowledge the work that our women especially are doing in this space. Like this resilience for Aboriginal people to adapt to changing needs and care arrangements in their lives, can really, really quickly, though, lead to burnout. And it's one of the reasons that we do need more awareness, especially in sort of clinical settings and in places like where we don't have to ask for the support ourselves, where it's somebody can sort of help and identify these things and sort of steer us in the right direction sometimes to say, hey, we can see that you're in this situation and we'd like to help. Next slide, please. And so ability. And so, as I said, we don't have any words for disability, but one thing I think that highlights ability is that for over 60,000 years, we've been able to adapt to our strengths and not our weaknesses. You know, like support is now available through forums like this one to ensure we can continue to provide the care for our families and that our mobs need. And the one thing I'm just going to leave you with today is a little bit of piece of Aboriginal culture, but I also think it's a really important piece of history for all Australians, regardless of your cultural background. And it also highlights, I think, the strengths of community resilience and ability. So the three key points that I've talked about here today. These are strengths that I believe all carers possess, and I want to acknowledge everybody here and in the audience's lived experiences, and also all of the people that are working together in this space to try and make some change and difference for everybody. So we'll come across to the next slide. So the Willandra footprints, some of you may have heard of a place called Lake Mungo. Really interesting thing is scientifically footprints can tell us a lot, right? And so these footprints have been really, really well studied. They're about 20,000 years old. It's footprints of a family group that have been left behind in the wet clay at Lake Mungo. And it shows us really what their life was like back then. So there was a group of men running quickly amongst these footprints, some at around 20 kilometres an hour, so running relatively fast. But there was also another man there running at 37 kilometres an hour. So that's almost as fast as an Olympic sprinter, and they think he was chasing an animal. So like the family group might have been hunting or looking for a feed. One of the other really cool things that you can tell from these footprints is that one of the patterns is from a woman carrying a baby on her left hip, who then shifts and changes the child over to the right hip. And I know anyone who's carried a baby before knows that that's something that happens all the time. Like, so, you know, your one side gets tired and then you need to shift over. The other child runs away from the group and then returns to them, and that's represented in these footprints. But what I think is really, really interesting, and as we'll go to the next slide, one of the men represented in these footprints only has one leg and a cane, and he's running as fast as the rest of the group. So that's the footprints there, and you can see the one leg, and you can see the footprint from his walking stick, and he's running at 20 kilometres an hour with everybody else. And so I think that this little piece of Aboriginal culture and Australian history really highlights the sense of community and group strength that we focus on. And also the same thing, you know, also sort of points to why we don't necessarily identify ourselves as carers, because we make do and get along with life. And so Gabaninda, everybody, thank you. That concludes my talk, and thanks for listening today.
Thank you very much, Luke. I hope my microphone is better. I've been told that I wasn't. And once again, highlighting the importance of understanding culture, understanding diversity. We're all not the same. There's differences that we need to understand those to provide better care. And lucky last, I hand over to Melissa.
Thanks so much, Giselle. I'll just share my screen. Thank you all for joining today. My name is Melissa Docker, and I'm the Acting Executive Manager of Policy Development and Research here at Carers New South Wales. It's been great to hear from the presenters so far, and I will be sharing a little bit about our project that is focusing on improving carer identification and support in general practice settings. As we've spoken about today, there are quite a few carers in New South Wales. There are approximately 958,500, and more than 2 in 5 carers live with disability, so approximately around 40%. For primary carers, the rate of reported disability is at twice the level of other members of the population. And we know that caring has a significant impact on carer wellbeing, psychological distress, and health. So as you can see in the National Carer Survey 2024, approximately nearly half reported fair to poor health outcomes. So caring can have significant impacts on a carer's own health, even where they're caring for somebody and supporting them with their healthcare. So in terms of carer experiences within healthcare settings, noting carers' own health experiences, we can see that around 80% of carers provide support with healthcare, and this is findings from the 2024 National Carer Survey. So in New South Wales, a large majority provide support and assistance with healthcare, but a lot of carers also provide support with activities or tasks that support healthcare, such as admin, transport, behaviour support, cognitive support, personal care, and checking in. We can see that when we speak to carers about their experiences in GP settings, positively, around 2 in 3 report that they are included in planning and decisions, but there is still a small number that around 1 in 8 who say that they are not included in those who disagree that they're included, and there are a number of carers who are neutral as well. When we do look at the qualitative data from these questions as well, we do also see there are a lot of carers who report that even though they might be included, they may not be fully included, or they may not always be provided with the information that they need. However, when we look at if carers are asked about their own needs as a carer, acknowledging that they have their own, a lot of them report their own health conditions and disability, we can see that a much smaller amount of carers are actually asked about their own needs as a carer. And some of that is in relation to the caring role, but that also extends to support with their own health needs. So less than 1 in 4 are asked about their own needs as a carer in GP settings. There has been some emerging evidence that caring is a social determinant of health, so especially from the UK. We know there's increasing reliance on informal care. Caring can have a negative impact on a number of domains that impact on healthcare, and I think Chiara spoke to a number of areas in which she was impacted by her caring role, which altogether, concentrated on her own health and well-being. And we know that there's, as I mentioned, a limited focus on carers' own needs within healthcare settings, even when they are often attending. So it's important to consider how we can start to look at addressing some of these areas, but also how we can consider and respond to carer health as an increasing issue. I just want to also note that some of the work that this project is focusing on does stem from previous Care Knowledge Exchange webinars. So we just wanted to feedback that how the Care Knowledge Exchange has influenced our own work. So we did run a Care Knowledge Exchange webinar in February 2023 that also focused an initial conversation on carer health, a bit more broader than today's session. But one of the questions posed by carers and researchers in the breakout rooms was there was identification that a lot of carers report similar health trajectories and preventable conditions such as hypertension, type 2 diabetes. And so there was the question asked that if there is a lot of similarities in carer health trajectories, is it possible to develop a carer clinical profile to inform and enable a proactive and preventative approach to supporting carer health and well-being? So since that time, we've done some work on looking at what this would look like. In 2023, we conducted a literature review to start to gather some evidence of whether there is similar conditions or similarities in health experiences across carers. And as you can see, there are quite a lot of similarities in the small number of reports that do exist. I will note that there is not a huge amount of research on carers' own physical health and physical health trajectories. We can see that those studies that do exist do show some overlap in things such as depression. Pain is also a high commonly reported, and general poor health habits, which might be contributing to some of those preventative health conditions. Additionally, we looked at the findings from the 2020 National Carer Survey, and we started to look at, we asked carers about their own health conditions and disability associated with their caring role. And so we started to group these together to unpack and understand what are some of those similar conditions that carers report. And this is self-reported. However, as mentioned, there is limited data available on the health conditions that carers experience. And we'll talk a little bit about how the project that we're working on at the moment will aim to support with some of this data. However, as you can see, there were quite a lot of areas where carers did report their own health conditions and disability. So In relation to kind of the new work that we're working on in this space, under the Carers Investment Program Grants Program that the Aboriginal Health and Medical Research Council project is also funded under, we are currently funded to deliver a GP carer awareness program. So acknowledging that carers report low identification and recognition in the community, and that general practices, including GPs, but also other general practice staff, so nurse practitioners, GP practice managers, as well as receptionists, are a key touch point in the community for many carers, given that they're often supporting others to access healthcare. But there's a limited consistency in practices around identifying and recording carers. And some of the systems that are currently used in GP practices do have carer questions, but they're often not used consistently, and in some cases, or used at all. And this really can impact on inclusion of carers in healthcare discussions, referral to appropriate carer supports, and proactive and preventative healthcare that's tailored to carer needs and experiences. So really targeting those potential preventative opportunities that are unique to carers and when and where those might arise. So the GCAP program aims to address these areas by improving the capability of all GP practice staff, including GPs, to identify, record, include, and support and refer carers onto the appropriate supports. In terms of what that looks like in practice, so it's a 2-year project that we delivered from April 2025, or that should say March 2027, sorry, my apologies. We're aiming to deliver education to 200 GP practice staff, so a carer awareness module that is tailored for GP practice staff. We are aiming to do direct engagement with general practices, so looking to do 32 general practice visits to promote and support carer-aware practices, and that's really about connecting. We know that GPs and GP practices can be a difficult to reach cohort, so we're trying to ensure that as well as having our broad sessions and promotion that are publicly available, that we're connecting directly with practices. We're trying to draw on approaches in other industries that also engage with GPs, such as pharmaceutical companies, to look at how they're able to access and leverage GPs to be able to provide this training and education, because we do know that it is difficult to get GPs and other health professionals to engage in this type of training, as sometimes it's not seen as directly relevant to clinical outcomes. So we are looking at a bit more of a targeted engagement approach. And we're also, so as mentioned, we had started some work on developing a carer clinical profile, and we had some initial conversations with Health Pathways teams, and it was determined that further evidence would be required to support the further development of a carer clinical profile, which we can hopefully then utilise in Health Pathways or update and support with preventative healthcare approaches. So the outcomes of this are intended to be increasing awareness and identifications of carers in GP settings. So I think that's come up quite a lot, that carers aren't identified within these settings often, and that's a huge barrier to referring them onto supports or enabling appropriate support. Improving the consistency of and in recording of carers in health systems. So it's difficult to understand the full trajectory of carers within health systems, what types of supports they're receiving, if that's not well recorded. Increasing the inclusion of carers in healthcare discussions around the person they care for. Improving the understanding of carer physical and health needs, of carer physical health needs, including that preventative approach. Increasing the targeted, proactive and preventative healthcare for carers. So really looking to tap into those screening that might be suitable, as well as preventative approaches, linking carers in early with the appropriate supports to address some of those health habits, acknowledging that carers obviously have very limited capacity, but how do GPs do that to support them? And increase referral to appropriate carer services and supports. So that's things like Carer Gateway, carer support groups, and other services and supports that might be available locally. So in terms of where we're up to date, so we have developed the awareness raising sessions. So we've established an advisory group. We've held consultations with carers, GPs, and GP practice staff. We've developed and piloted education and the education module and resources. So we do have 2 posters in clinics for carers. We have a poster for GP back of house kitchens or notice boards that has information. We've also developed some certificates for those who are participating to try and encourage participation as they're able to provide evidence of CPD. It's not CPD accredited, However, the certificate does enable them to log their own CPD. And delivery of the GCAP education sessions for practice staff. So we have been delivering those from February monthly. The next kind of steps in the education component is continuing to build on our community engagement. So we'll be participating in upcoming conferences. We know that it's difficult to reach GPs, so we are hoping to utilise spaces and environments where they're already primed for learning to be able to initiate conversations and engage them around carer inclusion and awareness. We will be working with PHNs, and we've connected with quite a lot of those already, but PHNs have good networks for GPs, so utilising and leveraging those networks, and as well as continuing to build on our contact with individual practices. So the other component is that development of the carer clinical profile. So that will kind of be the next phase of the project. And that will include revising and updating the literature review to include any new research, analysis of the 2024 National Carer Survey data, where we did again collect over 3,000 self-reported health and conditions and disability, and embedding carer clinical, looking at how we can embed the carer clinical profile and preventative and proactive health approaches in health pathways or other clinical guidance materials for GPs and GP staff. So in terms of the impact that we've had to date, as mentioned, we're still building in, so we have delivered some of the education sessions, but we're continuing to build on the process. And so far, the feedback that we've had from the sessions, positively, the February workshop, 3 practice managers provided feedback on how they would apply the learnings from the session, noting that they would make a note of patients about being a carer, keeping in mind to ask people they're a carer and to identify patients in practice software, and identifying and recording carers in best practice. So as we can see, it is really supporting, especially in the practice manager space, where they do have oversight of a lot of the administrative component, that consistency and reporting of carer data, and that will enable GPs to better see and understand and be aware, and practice nurses, that people are GPs or are carers or have carers. And we're hoping that that will support more carer inclusive approaches, including tailored support with healthcare. So I will, if you want to learn more, you can also request a training session, or if you'd like to download resources, you can visit our website, and you can also reach out to us at any time.
First of all, thank you all for such wonderful presentations. They are, of course, diverse and insightful. I have so many questions besides the ones I have here, but let's kick it off. So to start, let's consider the foundation of this work, right? Visibility and recognition within the health system. So this is a question for everyone. Why? The question, I believe the answer is pretty obvious, but I have to ask, why is identifying carers within the health systems essential for improving policy, practice, and outcomes? And I think we're going to start with key people here, the people with lived experience. So I'm going to start with Chiara and Luke. Over to you guys.
Luke, you can start off. I think I'll back you up.
Yeah, no worries. Thank you. I think it's really important because there's many different aspects of this, but I think one of the main reasons it's really important is because we look at the sort of level and standard of care that's able to be accessed, by people with care needs. Often that's outsourced support with regards to NDIS or aged care or like other external providers. And we know from our people's experiences that we don't always get the support that we need from those fee-for-service services, and it's much nicer for a person to be able to be cared for by a loved one or somebody, like with those skills, and I'm sure Chiara would agree on the sense that she probably feels like she knows her kids better than the OT does.
Absolutely.
And I would suggest that opinion probably carries for everybody in this webinar, in that you know your person better, right? And that person also probably appreciates your care better. It's a more comforting care than is available, like through an external person. So that's one thing just straight off the bat. So I think the standard of care and quality of life for our people, this hinges on that. Right. One of the other things, though, that attaches itself to that is the quality of life then for the carer. Right. So if the carer is not looking after themselves, they're in a harder place to look after the person they're caring for. And we've talked about things like self-medication and addiction and stuff like that. And this is how those things arise, isn't it? And you sort of all end up find yourself backed into a corner. And I noticed that people have, also talked about the NDIS changes in the chat too. So I might just quickly touch on that. I spent 6 years coordinating Aboriginal specific NDIS services. So I've sort of worked through a lot of the ins and outs and stuff. I'm really scared about how this will affect our people, or how this will mean that, I think they talked yesterday about 160,000 people getting kicked off the NDIS. So I know that for my community personally, Aboriginal people are quite highly represented in those statistics. So that'll probably affect us disproportionately in some ways. It's also going to affect a lot of people with psychosocial disabilities, with regards to diagnosis of schizophrenia and things like that are on the NDIS currently, but now may no longer be eligible and forced back onto other New South Wales health services, which we know aren't necessarily always the right places to be. So it's I think the biggest problem with the NDIS changes is going to be the disruption to everybody. We already know that the NDIS is very hard to navigate because it is a constantly changing situation anyway. They talk about things like this Thriving Kids program that's going to perhaps fall into place of it, but there's minimal information out there about that or the support that is available. And I think the biggest problem this creates is that it just puts all this anxiety back onto our people who actually need the support. It's not them that have caused any of these problems. Like these government decisions and lack of regulation and all of this type of stuff. And the people that falls back on is the carer at home, which is all of us, and so this is where that unseen and unpaid and everything work. This has the potential to increase our workload quite heavily. So I really think it's really important that we have these conversations and advocate for this. And as much as it's a changing situation at the NDIS, we don't have, or obviously sort of don't have answers for this type of thing yet, but I think it's something that's going to come to the forefront, and we're going to need to probably unite to get our advocacy and opinions out there with regard to this, definitely. But yeah, thank you.
I think I'd like to add a young carer perspective here as well. I think that's really important. Yeah, I agree with everything you said, Luke. I think one thing that young carers struggle with in the healthcare system is actually having their expertise validated. It doesn't matter if you're 8 years old, you know just as much about the person that you provide care for as anyone else. And I don't feel like our voices are respected or heard in the healthcare system most times. Without recognition and that expertise, just quality of care drops, as Luke said. If you're not listening to the carer that's right in front of you telling you that this medication doesn't work, or this standard of support is not adequate, it's not reaching where it needs to, of course, the recipient is actually going to struggle immensely. I think from, a policy standpoint, I feel like in the healthcare system, sometimes supports are not only placed on my son without, what they think is best. My son, I mentioned, has PDA, which is pathological demand avoidance. And everything you read about for ASD does not apply to my child, not in the slightest. But, that advocating is absolutely exhausting, and most times not even heard. So I will talk about a positive here, is that my son's support team, his therapists, have literally changed my life. When you have therapists that come in and work with families, for families, and they listen to them, they've recommended me things. And I said, look, we'll try it, but I really don't think it will work. And they come back, a month later and said, no, we're scrapping that. I shouldn't have even done it. Things that I struggle with is things can cause regression, and I think that's common across care recipients as well. So yeah, it's so important that they're identified, because also the health system has separate supports from from other mainstream services. I'd like to touch on the NDIS as well. I'm going to be a bit vulnerable here. I've struggled with a migraine all day, a really significant one this morning, and that's directly because of the NDIS announcement yesterday. My son, we're talking about carers' health. I literally had a numb tongue halfway through my presentation. So, I struggled this morning, and that's directly because I don't know if my son's going to have funding for a support worker in a couple of months. So yeah, the NDIS space right now is scary. I work quite closely with a couple of people in the chat, and I think they've heard about my journey within the NDIS system and how hard that's been. But yeah, there needs. I think the health system is going to take a lot of this brunt as we're moving forward. But with that, there's opportunity for carers to be lost in this. So yeah, I think we have a lot more work to do. I agree.
Well, thank you, Bert. I feel that the questions and a lot of the chat comment, of course, a lot of anxiety and what's next in the NDS, and someone who is in the disability space, a lot to say about that. I feel like I need another 2 hours, probably half a day to discuss these very important points. But again, some of the Q&As, I'm just going to move on to something that you also touched as well, Kiara, acknowledging, the limitations of what's going to happen to NDIS and the problems that it will cause and the impact it will have in the health of carers. But I'm just going to move to, where do current policies fall short in supporting carers? Because it's something that you mentioned, Kiara, about the policies. So from policy gaps, we now turn to how well the system meets building on that, it is important to look at how current systems and policies are performing in practice. So I feel like there was something very particular that you said, Kiara, that is, we need to change the policies as well. And I'm handing over to Anslin to kick this off. And I think after that, I'm definitely going to open to the Q&A because I feel like there's a lot in there that we can tap into. So Anslin, over to you.
Thanks, Giselle. Yeah, absolutely. And I think, like you say, with everything in the chat, I feel like it's a number of the things that have sort of come through is about sort of media action. And I can see in the chat where people have said they've gone to their GP, and this touches on some of the things that Melissa brought up in her presentation as well. And they're not getting recognised as a carer or the role that they're providing. This, and again, thinking about what Luke and Kiara have said. So you're hidden even though you're there, you're present, but you're not getting recognised as the carer, and then that role that they're providing is not being identified or supported. We use the analogy of, if you get on a plane and you've got the oxygen drops down, you're always told to look after yourself first before you help other people. And oftentimes what's happening is it's being directed to the care recipient, which it should definitely, but the carer themselves is not being addressed. So there needs to be more in the space of like systems being able to support and enable both the carer and the care recipient to be addressed as a holistic whole, not just the individual, acknowledging obviously that they need support as well. But if we don't support our carers, then we're not going to be able to have them longer term. And all the discussion about what's going on in the NDS has previously been happening with aged care as well. There's so many changes. People are under more pressure and there's adding more burden to them rather than easing that. So yeah, that's what I've got to say. And I can see others nodding there. I don't know if Melissa wants to add from your work that you've been doing within the GP space.
Very similar to yourself, Ashley. And I think there are some key policy barriers to enabling carers to be recognised. I mean, the awareness is a huge part, and that acknowledgement of the role of the carer, but themselves as an individual. But the Medicare system could they're changing or adding additional items to enable carers to access specialised appointments that are recognising their role, that we've seen happen in the mental health space. They are available in the mental health space, but they're not available. And if you are using them in the mental health space, you do have to use 2 of the better access sessions. So it's not even on top. It's that you have to take away from the care recipient or the person you're caring for in order to be able to access those family sessions. And I think one of the key things we see is that carers prioritising the healthcare of the person they care for, because it is often someone that they deeply care for, and they want, if it means them or yourself, then we see carers put off, a lot of the screening, a lot of the appointments, diagnostic, even treatment, because there's a cost choice and you have to choose where you spend the money, and if it's on yourself or the person you care for, or if you have the time. And I think, Kiara, I think you spoke to that a little bit in your sharing of your experience. But the financial cost of healthcare and the increasing co-payments and the increasing gaps that we're seeing in the medical system, and especially not just the medical system, but if you are trying to access your NDIS or your aged care, the cost for assessments in those spaces as well, in that primary care setting, it really often does position it of you or them, which it really is a challenge and something that needs to be addressed so that everybody is able to access the support and the healthcare that they need. And especially, healthcare carers, we know they're isolated. They experience social isolation. They might not be able to participate in community activities. They might only be engaging with healthcare professionals or service professionals. It's such an important touch point that if carers are not picked up in those spaces when they're there and acknowledged and recognised, there may not be other places where that can happen. So it's such an important place, and looking at the quality standards and how carers are connected in with consumers, they fall under the same kind of heading. That often means that the carer isn't really seen. The person only thinks about the consumer and not the kind of family or carer, which is part of the consumer definition in a lot of the healthcare standards, but it isn't the front of people's mind. It just kind of is, and carer, which doesn't create the carer as their own person with their own individual needs.
Yeah. Well, thank you all. There's so many things in there, and I think the chat is going again on fire and agreeing with a lot of the things you're saying, and same with the questions a lot around the healthcare, a lot about general practitioners and their lack of recognition, how the system is failing. But something that went through my mind, and sorry, it was something that Karen, I think, was a mind reader, because this is exactly what I had, is the lack of integration of health, disability, and aged care, right? We work in silos. It's not like we're one system that allows people to navigate. It's just people have to navigate different systems, and it's quite complex. Which leads me to the next question. I promise is the last one, and then I'll hand over to the chat. And it relates to how well the system meets the needs of diverse carers. And I think this is an indication from both Kiara and Luke's presentation, and also Ansley, that there are different needs. So how can the system better respond to diverse carers, including First Nations, cultural and linguistic diverse backgrounds, and carers with disability? And this is a question for all of you, and then I'll hand over to the questions in the Q&A.
I think, Luke, I'd like to highlight your First Nations perspective here, please, and then I'll jump in for
yeah, cool.
Wonderful.
Thanks, Gary. I think the biggest thing in this I think, yes, from a First Nations perspective, but I think this applies to all communities, right? We've just got to get better at recognising the people who are standing in front of you. This comes from relationship building a lot of the time that our clinical settings aren't very good at. If you've got a regular GP, they should be getting to know their clients a little bit better than to know that if, it shouldn't just be the sort of wham bam thank you ma'am appointments, for want of a better expression. And in that sense, identifying carers in general, and so one of the things I think Melissa talked about was as far as I'm aware too, there's only a handful of patient information management systems that all GPs use. One of them is best practice. Another one that's used by a lot of our services is Communicare. And so at an administration level, there's lots of things that we can do, as providers, that will help this. There should be flags built into systems, so every staff member who opens that patient record knows that there is a carer, right? I know it's possible within best practice and Communicare that you can have it come up as like an alert, that basically somebody types my name into the thing, they'll be like, oh, Luke cares for 2 boys, blah, 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 right? And then if the receptionist happens to miss that when she books me in, it pops up for the nurse as well at the next stage. And then if they have missed that, then it pops up as well again by the GP, and this is the hardest part though. So because we aren't getting good relationship-based care, we need to have better processes and systems that we can embed into services to make sure that they are catching us, and can reach out to people who aren't comfortable to self-identify or self-seek support, and we know that carers come in all shapes and sizes. It really is a heap of different models, I suppose you would say, of what a carer family unit looks like. It can sort of be anyone and from any angle, and that's something that as a society and a community, I think everybody needs to be better at, to help us. And I think also in forums like this are really important too, because it gets to have everyone's voices out there. So make lots of noise, stamp your feet, everyone. This is really my best advice.
No, I just wanted to touch on that a little bit. So one thing I think gets lost is most of us from, I think everyone in the caring space, but particularly from, different backgrounds, a trauma. There is so much trauma in caring. There's so much trauma specifically for cold as well. And if you don't mind, Luke, I would assume for First Nations as well, right? It's riddled with trauma. So right now, for my personal experience, my family's overseas in a war. That's never thought about in a caring role. So again, just relationship-based care. And I agree, Luke, if there's not enough time for that, which we know our health system is stretched to its absolute breaking point right now, then I agree there needs to be systems in place. And I think we're getting better with the practical things. So for example, like translation, what are they called? Sheets? The ones where, everything's in a different language. I think we have a long way to go for First Nations in that area. There is not enough representation for local language there. But, that's really where it stops. It's like, okay, we've ticked that box. They can read it, but can they understand it? Can they understand the system? Can they understand the consequences of that? Are they making informed choices? And yeah, my partner's from a Maltese background. And even then, his family have been in Australia for literally most of their lives, and they still struggled accessing basic aged care services. That's something I remember. Bless her. Hayden's grandmother told me that, thank God that you've come along because I can finally, read I can get someone to just tell me what this mumbo jumbo is on a piece of paper. And, that's an additional burden on carers, specifically young carers who come from different backgrounds. There's so much that we need to do better. And I do think the root cause of it is just building relationships and understanding the person in front of you. And I don't think that's that hard. But yeah, I don't think we're going to get adequate resources anytime soon. So then we need to start building processes and systems that make sure carers are not lost.
And I think just adding to that, I think both of those, and it's just listening. And I think not making carers do the work, I think is the main thing. That it's the responsibility of the sector to understand what carers are, who they are, that they're anyone and everyone, and that can look really different. And it's the responsibility of those professionals to listen. And someone is not likely to have the words for a carer the first time or when they're talking to people, they might not have that word in their language, but also their role is just family or wife or husband or partner or mum or dad. And so they often are not going to be able to express that they're a carer without some kind of conversation around that. And part of the barrier to accessing services and supports is often knowing the right language, like knowing that you need to access Carer Gateway, but if you don't know what a carer is, who's Carer Gateway for? And so it's the responsibility of the professionals and the services and the supports to have that understanding and to do that work and not expect that someone will come to you and say, I am a carer, because the likelihood of that happening is not likely. And if a carer doesn't want to identify as a carer, they want to maintain their identity, that doesn't mean they can't access those supports. And it's about supporting them with that, navigating that journey of identity and how they can still access all of those things and what they are comfortable with and where they want support. And I think it's a bit of that, overlay of we're often telling people, oh, well, if you're this, then you must want this support. And it's about listening to actually what they want in the moment and what their family needs, as opposed to professionals and clinicians putting their lens over what carers need and the experiences and what we expect a carer to look like or yeah.
Can I just quickly add something? I'm so sorry. I'll be very, very quick. I just wanted to say, and I think it's important to note that they don't need to tell you anything for you to offer them support. And I think that's what gets lost. I agree, Mel, that the onus should never be on the carer to then have to, say, I need help. That is what a health system is for. That is what, NDIS is for. That is what community supports are for. And I think the onus is on the people with the position of power to then, offer supports. And they don't need to identify as a carer for that to happen. You don't need to say, I'm a carer to then get to offer something or offer carer gateway. So I just wanted, that was very important to me. So,
no, and there's a couple of questions actually asking you exactly what you just replied to. So I'm going to bypass those. But leading to the next question, I'm going to the audience. And someone asked if there are any tips where to begin this conversation, which I find quite interesting. So the onus is now in the person. If the provider is not engaging, they're asking Kiara, what do you do? So it's kind of very interesting to kind of that counterpart. So what is your answer, Kiara?
I just want to highlight John, who answered that question. He's a fabulous young carer himself, and he's one of my favorite people on the planet. So please connect with him and hear him. I would welcome. I know he's very open for questions himself. So, but I know what John's asking there, and I think it's both ways. I think in every space, education, health, people are scared to ask a question, and I always say, don't beat around the bush with young carers. We don't have the time. We don't have the mental energy. If you think that we need help, ask. Literally just ask. And I gave an example. What do you do outside of school? Who are you, if you hear a young carer talking about taking their brother to therapy after school, there's your... they're a young carer. Like that's your inkling. I don't think it's difficult, but beginning that conversation is literally just a question. And most of the time they're going to lie. I know I would have out of fear. As I said, we were in CPS for over a year, or FACS or whatever their name is. But so we were dealing with them for over a year, and they're most likely going to tell you no. But again, the onus is on the person who hears. I always talk about the education system a lot. So just for an example, teachers, if you hear a young carer talking about taking their, I just got to call mum quickly, like I want to check she's okay. That's where it is. So just start the conversation. Just don't be scared to ask. You may not get the answer that you want or need, but there is enough there. And I'm sure if you just listen for 5 minutes, you'll be able to help them in some capacity. So just ask. Just ask.
Which is a perfect, again, Glenn already, sorry, Luke, just to tap into that it says, why don't you identify young carers within the school system, and how can we avoid that occurrence of concerns about family services for an intervention? So providing a safer space to talk about these things. So just answering Glenn's questions, and over to Luke. Sorry to interrupt you, Luke.
No, you're right. Please move on to the next one.
Are you sure? Well, yes. So
those can I add one more point? Because I just like to gap and everyone likes to hear me talk, apparently. I will be quick. I just want to say as well that flagging someone as a young carer or a carer in any capacity does not automatically mean that facts need to be involved. That is not an automatic indication of they need to be in this system. That is not an automatic flag. What that should be a flag for is they need support and they need resources to help navigate this. But they're not, of course, if you have any concerns, mandatory reporters have a job to do, and I understand that, but it should not be the only distinguishing factor of whether you report them or not. That is not a need for concern.
Thank you, Kiara.
Barrier, the fear of reporting and the stigma is such a big barrier to young carers speaking about what support they need and what would help. Yeah.
So I'm going to go for another question. That is there a role for, and this is the last one, unfortunately, but is there a role for social prescribing in enhancing the role of GPs in supporting health and well-being needs of carers, in particular in the preventative health context? And I think both Melissa and Ainsley can talk about this question.
Do you want to go first, or?
Yeah, you go first, Melissa. I think it fits well with yours, but I agree.
I think it's a conversation that we've had quite a bit about the role of social prescribing and the value that it could provide, given the social, the low social connectedness that many carers report. I think where we see some of the challenge is that GPs are feeling overwhelmed. We know that a lot of the so there's a lot of services in the community that have deteriorated, especially. I know that case management is obviously not the only or best support, but a lot of that kind of support around navigation, paperwork, administration of services and systems has declined. And so what we have seen is that that has often fallen to GPs. And I think with other services reducing and GPs are a main touch point, we're seeing more and more onus being put on GPs to pick up other, and it is important for holistic healthcare, absolutely, that they pick up those other components. But I think what we're seeing is that GPs are feeling overwhelmed with all the things they're trying to cover off on. And especially, I think, within the current Medicare environment, where we know that a lot of GPs are having short sessions because they're saying that the rebate doesn't cover, and we've already got big gap costs. I think if you were to add a Medicare item or acknowledge that or include it to enable or have those longer appointments, potentially it would be a great opportunity to build on, and that could tie in with carer-specific appointments, or it could just be general appointments for everyone to get social prescribing. I think it would be great, a great opportunity. GPs have such an important role, but I just foresee that without kind of that policy change and that infrastructure, there will be limitations in how much they can engage in that, or their willingness to kind of take that role on.
And unfortunately, we run out of time. So I'm just going to take 5 more minutes. And I know we can continue this for hours, but I'm just going to wrap it up. And sorry, because I know there's so many questions. The chat will try to reach out to people, maybe a Q&A afterwards. So maybe we need a part 2 of this session. So I'm just going to take 3 more minutes of everyone's time to wrap it up. So before I move on, I just want to have this key point summary. Carers definitely need to be supported to look after themselves without the carer having to ask for services and supports, and the need to identify them, recognize them, include, inform, and support carers proactively. It needs to be more person-centered, so always seeing the person first. That's pretty clear, strong messages. The second thing, it was the health systems and GPs are a decisive point of contact. If carers are not identified there, they may not happen at all. So the support needs to come across services landscapes, NDIS, aged care, and other government services, family supports, child protection. And I feel like there needs to be more education across the sector about how to start the conversations. What are exactly what you said, Kiara? What are the flags that you can identify to support them? And I'm going to leave it there because I know we're definitely running out of time. So after yourself, please. And then this is a quick plug. Then we have the Care Knowledge Exchange, which is a digital platform, and you can browse and share care-related research publications. I know it's not for everyone, but it's a research library, and there will be short presentations on the Spotlight series. Some people, I know there was a lot of talk about research and more research and where this is heading, so check that out. I also want to invite all the participants to subscribe. Make sure you are notified about the next steps and receive the recording links. Make sure you're subscribed to the Care Knowledge Exchange so you can hear about more of these amazing conversations. And there's also going to be a launch of a feedback poll, so tell us. I loved it. Obviously, I'm extremely biased, but I think I learned a lot. I feel there's lots of things to be done, but I am encouraged and motivated to work in this space more. Once again, thank you very much to all the speakers. Thank you for sharing all your experiences. It's been an extremely incredible experience to be part of this. And with no further ado, just hit us on the poll. And sorry I had to rush at the end, but I know people, we can be here forever. I can be here forever, but I know we have to go back to, we did promise at 12 o'clock. So it's 12:02. So I, once again, thank you everyone very much for being here. And with that, share the poll, and we look forward to seeing you at the next webinar. So thank you very much. Subscribe, follow, and thank you everyone for being here, and to all the speakers.